Ben.
Well, good morning, everybody. This is December 6th, 2023. My name is Jens Chapman. And on behalf of our SSF team, I welcome you all to this program. It's STED Talk time, spine technology education, and the D, as I always point out, is up for discovery, debate, however you want to call that. We'll have the D be multifactorial. It's a great pleasure to have our guest speaker not just in attendance in an online environment, but here right with us. Dr. Anubhav. Amin is an assistant professor in neurosurgery. I'm going to introduce him later when he goes to his talk, which will be about minimally invasive approaches for tumor treatment. And he's already in his short time here, well-known and well-recognized oncologic specialist. He's a neurosurgical colleague in the ortho and neurosurgery combined program. And he came here despite an injury. I'm just going to preempt that. So we are particularly grateful for him to having taken the time out to come here. And today's topic is again going to be about spine tumors, but as always, we have a couple of cases first. Before we go into the case discussions, just a little advertisement in our own matter. This weekend, we have our annual robotics course with Drs. Pat Johnson and Danielle Drazen. And it's been retitled as Anything Cool in Spine because they'll have all the latest technologies here. And so this is very nifty. So spine robotics, and Ben has flashed up the advertisements, the 8th annual course. And I always love this course because it has so many cool features in it, and industry is really adept at bringing us the latest and greatest, not just in robotics, but yes, you'll have an all-out robotics and simulation and navigation lab. So I hope, Dr. Amin, you'll make it there also, because we like, especially young, pushing people who push the envelope to be there and push us older people along. And then the weekend thereafter, Ben, can you flash it up? We have the spine trauma course. It's the 9th annual spine trauma course. It's always my favorite course in the year, and Ben put a really nice logo together for it, very explosive. And that spine trauma summit, December 15th, 16th, we have again a national and with inclusion of Canadian colleagues, almost international, and German colleagues, a group of people here who are going to talk about spine trauma, the latest, greatest in that. And as always, we have a couple of colleagues on the East Coast who are well known to be very happy to talk and stir up trouble, especially Dr. Harrop, neurosurgeon from Jefferson, and Dr. France, vice chairman from West Virginia. They're well known to be rather outspoken people. So I hope you'll join us virtually or maybe even in person right here for the next 2 weekends and this December. Without much further ado, and yes, I've indulged your patience very long here. Let's go to the first case, which will not be an oncologic case. After that, we'll switch to oncologic themes. And Dr. Davis, D3, as he's called here, is going to talk about a case in the more recent past. And as always, will not give dates of actual care. Okay, thanks.
All right, good morning. Thanks for being here today. And hope you have a speedy recovery. We have 2 cases today. I have no relevant disclosures and all patients are de-identified. The first case involves a 70-year-old male with underlying diabetes. He presented initially from the spine side with low back pain, and this was preceded by cellulitis of the lower extremity after a small burn wound on the foot, and this is the sagitals of his initial MRI. His labs initially showed he had a white blood cell count elevation and an elevated CRP as well. He had no neurological deficits and was found on his admission to have GBS bacteremia. We did recommend that we got an MRI with and without contrast of the C-spine and T-spine, which was not done at that time by the prior team, and then a course of IV antibiotics.
So let me stop you here for a second. Dr. Amin, I don't know how it is for you at UW Medical Center. You're mainly based at UW Medical Center, not so Harvey. Are you inundated with infections? I'm talking about de novo infections of the spine like we are. Is that just,
Yeah.
can you speak in the microphone? Sorry.
Yeah, it definitely feels like we're getting more and more of this year by year. And it's not, oftentimes, it's not just your standard IV drug use history. We're getting a lot of these with no obvious risk factors too, which is kind of perplexing for us.
So we're not burdened with this in an isolated fashion.
I think we're all sharing the burden.
So this is a ubiquitous problem here. This is a actually very nice citizen. He takes care of himself, very intelligent person. And still he's beset with this curse of diabetes and living along while there's an internal time bomb clicking. And he's not the thinnest person. You can see that there's adiposity there. But before we go into the infection aspect, who or do spinal infections have a home within the spine community? You're an oncology-oriented spine surgeon. We have trauma-oriented, we have deformities. Where does the management of spine infections fit?
Yeah, well, I think, as you know, most of these come in on call. So I think everyone, regardless of your subspecialty of choice, deformity, MIS, you're going to be seeing this majority whenever you take call. And so I think we're all responsible for pitching in with this. And I think there's a lot of, the initial event where you may have to do a washout or whatnot. But oftentimes these patients, once they have like a burnt out osteo, they can become a deformity case, as these often do.
And should they be on an internal medicine service or should they be on a surgical service? There's a little innuendo in the very bottom paragraph of the word part of the slide. Who should manage these patients? Are they best taken care of on an internal medicine service because they're usually polymorbid, or should they be on a surgeon service where protocols that are surgeon designed are followed through?
Yeah, certainly this is a double-edged sword where we ideally would like to do that washout and have depend on our medicine colleagues for the figuring out the PICC line and all that issues. And then it's a double-edged sword because a lot of your plans may be conflicting with theirs or are tough to enact those. So we run into that issue all the time. And a lot of times these patients may have a very long dispo where, it's a bit burdensome for them to be on a busy spine service. If they're some of these patients, especially at Harborview and probably down here as well, where you may have issues with homelessness and drug use, so they may not be able to be discharged with a PICC line.
So I don't know where Dave is going to take this case. I know where it's going, but would you have any troubles with this patient being treated non-surgically?
I think initially, if no focal neurological deficits, I think we would do the same thing. We'll try to avoid an intervention, and we would just try to closely follow him with daily rounds.
Would a needle biopsy be necessary, indicated, preferable, desirable in this setting here right now?
Yeah, usually I think if we see cultures speciating from the blood cultures, we would probably hold off unless they're not responding.
Yeah. All right. Do you want to take us a little bit further?
Yes, happy to. So interval history, the patient during a course of 6 weeks of IV antibiotics felt better overall, did develop a little bit of neck pain, and then eventually developed shooting pain down the right leg and the left, and still had no reported motor focal deficits, no incontinence. Then came back for a subsequent presentation. Apologize, those were not automatically running. And so now I've given you the comparison MRIs 2 months later after a course of penicillin G for the treatment of GBS. And
so I'll ask my partner and the Chief of Spine Service, Dr. Oskuian. Oh, you can have a microphone, yeah. Good. So was something missed here? I mean, this man got IV antibiotics. He never got a biopsy, so this might be discussion worthy. He didn't get the full imaging setup that we usually recommend, so the pan spine, MRI and CT. I'm not sure he got an attempted immobilization, but he's a pretty large man. I'm not sure his glucose was managed. So protocol driven, and who should take care of these patients? Is this an internal medicine problem? Is this a ID problem? Is this a spine problem?
I think, these cases are typically, they usually have an underlying autoimmune or, they're complicated cases. And so I think ideally medicine is usually involved. And what's interesting is that as soon as something shows up in the spine, everybody runs, right? Immediately get a spine consult. But I do think, as we've seen over the last several years, I mean, these are becoming a huge problem. And I do think, just like the SINS classification, I do think it matters, like its location, where is it? Is it lumbosacral junction, cervical thoracic junction? Does the patient have neurology? Is it osteomyelitis? Is it discitis? Is it an epidural abscess? So they're very complicated cases. I can't say, Jens, that I would say there's one treatment for everything. But actually, one of our fellows just wrote a great paper on this, and it's basically very similar to the SINS score. It's the site score where you factor all these things in and you say, okay, these patients are at high risk. For example, this patient is going to need surgery, right? We all know this. They need to get a full workup, echo, pan spine, MRI, CT, all these things. So in a simple answer, Jens, I think these are extremely challenging cases and you need to have a good team is what I would say.
So that's a great answer. And again, you point out why we're showing this case. First of all, spinal infections don't have a real home within the subspecialties of spine. And oncology would actually be kind of maybe the most logical target. So this is why we're showing that to you also. Because again, for instance, in terms of decision-making, the SINS score, and we'll talk about that later with Dr. Amin, has become very well established, but within some modest modifications, you can actually apply that for infectious disease patients also. There's an underlying other problem. Dave, can you point that out in terms of the larger big picture spine changes that this patient is ensconced with?
Yeah, I can point out a few things. There's definitely ossification in the anterior longitudinal ligament, has stiffening bone disease. He's developed a listhesis at 5'1". We don't have a comparative CT scan, but I think it's clear based on our CT that the significant erosion into the L5 vertebral body and the S1 vertebral body with this large gap. And I do provide some measurements later on in future imaging. I would say
he does have L5 radiculopathies, which
and new L5 radiculopathies,
yeah.
Yes.
So with a partial drop foot, and it's hard to estimate whether this was present early or not, because again, he's a larger diabetic male, and to some degree, numbness, tingling, some weakness, some gait limitations are always seemingly accepted. But now he's blown out his foramen completely with this heterotopic bone and whatever that is, tissue metaplasia. Sure. And he has, again, significant mechanical pain. This is a very stoic man. This is not somebody who cries. Okay, you have the and going.
So the and, we have these imaging, and I've provided the T2 and the STIR at the time of our second presentation. And you can see an infectious process as well in this C5-6 space here.
So Dr. Amin, this is great. Go ahead. Sorry.
Thank you.
So this is a great summary slide. Neurology, absence of neurology. This is always so difficult to point out in these diabetic patients because they are said to have, quote, neuropathy. And people really have a hard time, and I think that's fair, to differentiate neuropathy from radiculopathy, from frank neuropathy in terms of motor deficits from mechanical causes, for instance. So how do you suggest we as clinicians differentiate neuropathy as a end organ disease affecting the neural tissues? I know you've done spinal cord injury research, from simple mechanical myelopathy, radiculopathy type depictions.
Yeah, I think the first, this is where really it's important for the spine surgery team to be involved with that. We'll probably be better at distinguishing that. And first off, it just starts with the history, talking to the patients. They'll tell you whether it's a diabetic neuropathy or often I'll see patients with chemotherapy-related neuropathy, and they'll tell you that the symptoms they're having right now is very different than their standard neuropathy. So you can kind of get a feel for them of what their time course is and how it's changed in relationship to the inciting event of this. infection. And then, of course, just the exam and seeing if you can correlate where their new symptoms of weakness or numbness, if that's making sense with where the nerve impingement is.
So his cord compression, his cervical spine is actually pretty profound. I think I measured like 5 millimeters or 4.8 millimeters. He does not have overt cord signal changes. As a threat assessment, what would you put the priority? And again, he has neck pain, he has back pain, but again, an extremely stoic man, very, very engaging person. So where's your priority concern here?
Yeah, usually when dealing with these type of tandem lesions, I tell the patients it's all about location, 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 and the higher we're going up the spine, closer to the brain, becomes more and more the higher priority for me. So even though he may be symptomatic from the lumbar spine, I would counsel the patient. I'm worried more about how tight it is around the spinal cord there, and I would try to address the cervical before the lumbar.
I think that's fair. All right, and then I gave this break slide to give Dr. Chapman a chance to
I've babbled
acquire our plan, but we got there. And then so we had treated this in stages. I believe I've lost my feed. Let's see. No worries. All right. So stage 1.
So Dr. Oskurian, so you talked about the team approach, and this is so important. Again, I was unavailable, I was on call. Dr. Oskurian, what was your thought when I asked you to help me? You heard Anubhav's thoughts as to how to proceed. Where were your thoughts as to threat potential and what to do first?
I mean, I think clearly the neck was more of an issue, and so we dealt with that. And again, I mean, you can keep them on antibiotics and you'll just probably watch those vertebral bodies melt, and then you have to do a corpectomy. So I think, it's an easy enough operation that, and just given everything that was going on, maybe took us an hour to do this, and the guy actually did great, so I think it was the right thing to do.
Appreciate that.
So cervical spine, Dr. Amin, any thoughts on how to proceed and biomaterials? Again, we have an infection patient, so is hardware safe in an infection?
Yeah, I think a lot of times our infectious disease colleagues would try to convince us not to use hardware, but I think there's quite a few papers out there that, typically using titanium based grafts, we can put them in through infection and just continue with antibiotics. I was also going to comment about the timing of surgery, where I found that going in from early in an infection is a little bit easier, even though there's more inflammation. But if you try to go a couple of weeks later, if you were to do like a corpectomy, it's just completely matted down, scarred down, makes it much more difficult.
Yeah, I agree. I mean, I think, again, if you saw the MRI and CT and intra-op, I mean, it was just like, I could have taken both those vertebral bodies, I mean, it was just mush. So.
From the perspective of a fellow and trainee, when, if ever, would you involve an approach surgeon for the anterior cervical? Would you have an ENT involved from an early stage, or would you?
Yeah, I was also thinking about that I usually, because we're at the benefit of a big academic institution, we're having residents and fellows there 24/7. So I usually would at least keep them in standby or give them a heads up that, hey, we're going to take someone, I may need help with that. And we have a good relationship because of a lot of our oncological cases, we'll get them involved also.
Okay.
Was the approach difficult?
I wasn't in this case.
No, it wasn't too bad. Yeah.
There was some
Microphone, you got to use a microphone, nobody can hear you.
Yeah, it wasn't too bad. There was some scar tissue in the prevertebral space and everything, but once we got in, there was an osteophyte, there was this floating that we took, and we were able to create a space to get the intervertebral cage in, but yeah.
And the intervertebral cage is what material, what biomaterial?
VG2, it's just allograft.
It's just allograft.
Yeah.
All right. Stage 2. So we decided for this gentleman that he would, because of the unstable spondylolisthesis, we measured on a previous slide. I did not comment at the time, but we measured 16 millimeters on the anterior cortex. And so we decided to reduce the spondylolisthesis, do an L4 to pelvis, and use a rise cage would be appropriate for this space.
So again, you've obviously, Dr. Amin, as a young surgeon, been very enthralled with the MIS movement. We did a conventional posterior midline incision here. Are there any less invasive options? Do we do something radical? Are we endangering? You see all those staples in the back.
Yeah, no, I think I would probably do the same thing. In the past, when we do have an infection, sometimes what I've done is in the early acute phase, if it's just like a large spinal epidural abscess and I'm not as concerned about osteomyelitis and the deformity there, I've done a quick washout laminectomy midline approach or through a tube. And then if they progress to the point of need of having instability, then I can just do perk screws, which is kind of nice to avoid going through the same incision. But yeah, I think in this type of scenario where you clearly are going to need to do a good fusion arthrodesis here, I would have done the similar approach.
So we used 4 rods here. We have a short rod system. We call it the working rod around the L5S1 junction, and then a spanning rod to neutralize the already ankylosed L4 segment to the pelvis. Is that overkill?
Oh yeah, I was going to ask you guys about that. It looks very nice there, and the advantage of the quad rod is it because you're very concerned of the stability down given the amount of erosion there, because it's not like we're getting a huge correction with this, right?
Actually, yes. So this patient on the table, you didn't download a floor, but that's not a criticism. So this patient actually, and this is a question I have for Rod also, had a spondylolisthesis. Did you have a slide for that?
I showed the initial CT scan.
Yeah.
So he actually had a spondylolisthesis, and because of his larger abdomen, we put him onto a Jackson table. And when we had debrided him and cleaned out his 5 roots, he went into a easily, I don't know who was with me there. You're part of it.
I was.
This was easily a grade 2, if not 3 spondylolisthesis, past the 50% mark. His L5 just literally fell forwards. So it's actually very grateful. We put extra large screws into L5 and we put them deeper and then put S1 post screws in below the area of the defect. And we had to do an active reduction.
Wow.
Only then could we put the cages in. So this was not a trivial situation. I mean,
He doesn't have much of a sacrum, it looks like.
yeah, we had to be very careful how we put the S1
Yeah.
screws in. It's a very astute observation.
Yeah.
So here, putting a quad rod in was almost a necessity just for the deformity reduction. And I was actually happy about that. Mechanically, we've been very happy with those. They're, again, a healing impaired patient, they're substantial. We did use a full disclosure off-label bone morphogenic protein. Actually, we had this great session with Dr. Steve Garfin in our Evening with the Spine Surgeon series, and he's actually the originator of that and published on that like 15 years ago or so. So this is due to its pro-inflammatory qualities, a very helpful substance to use, obviously with adequate debridement. And we use titanium here to have a less offensive biomaterial than PEEK. Would you consider going the front in infection patients in a lumbosacral junction?
Yeah, that's another great question. I've asked some of our vascular colleagues with that, and they also have raised concerns about mobilizing vessels in that type of inflammatory state. So I've tried to avoid it.
Yeah, just recently, again, having to take out hardware from the front where we had a fortunately contained common iliac vein injury with an extremely experienced access surgeon. This is no fun going there. Absolutely not.
All right.
Thoughts from your end?
No, I mean, it's a great learning case. I appreciate your insight to it. I think infection is always a little bit scary.
The stepchild of spine. Do you have that follow-up case?
I do. If we're ready, let's.
So we're not just doing big open surgeries.
Oh, well, this was also, that's why I was a little bit confused.
Okay.
This is the 70-year-old man, a history of multiple revision discectomies. Many years ago at an outside hospital, he had a foot drop, as you can see in our Asian motor tables, and now has neurogenic claudication with multiple levels of severe stenosis. He has a degenerative scoliosis, as you can see, and here's his initial CT myelogram.
All right, so
All right.
multilevel spondylosis,
Yep,
okay.
we all agree. So his initial procedure was a lumbar 1 to 5 laminectomy with a 4-5 fusion. And it'll take us through the sagittals there as well. And you can see there's a wide laminectomy done with a 4-5 interbody. Interval history, the patient developed post-operative urinary retention. He started having to straight cath himself at home and developed silent anesthesia and some fecal incontinence. He had no reported change in his lower extremity motor exam. And you can see, hopefully, the T2 and the STIR images there. Maybe the screen is a little bit dark, and I can lighten that up next time. And then you can see his labs here. Here's afebrile. So at this point, I'll pause in case there's any comments.
That's okay. Now let's proceed.
And then, so he was taken back that day for a revision washout.
Okay. I know it's not the case I thought about, but that's okay.
Sorry,
That's okay. I was not specific. My fault. My bad. Yeah, we were going to show a percutaneously done far lateral case appendicitis with a percutaneous
nice.
posterior fixation. So we do that also. And behind you sits a wizard of far lateral surgery. So,
All right.
Thanks.
Thank you.
Any questions, comments?
No, it was a great case.
Dr. Neil, Dr. Gautam Rao, we're so happy to have had him here. His time here is coming to a close, end of the month. He's going back to the University of South Florida. He's from the Tampa Neurosurgery Program, did a great job here, and we will miss you sorely. And he has selected a oncologic case.
Thank you, Dr. Chapman. Let me just pull this up. Let's see. One more time. Let's see. And do you know where this one goes?
Oh, I'm sorry. It goes in the one connected.
Tape down. Is it over here? Right there. Nice one. Sorry. Very good. There we go. Great. Thank you, everyone, for joining this morning. We have a case presentation, no disclosures. This is a 45-year-old female. Unfortunately, was diagnosed with ER/PR positive, HER2 negative breast cancer back in 2020. She kind of had a lot of just palpable breast masses, biopsies, and eventually had that diagnosis. She was status post chemotherapy and radiation back in 2020, and was currently on Lupron therapy. She was doing well until earlier this year. She started having neck pain, trapezius pain, and some tingling and paresthesias down her right upper extremity. Her motor exam was without any focal deficits, no evidence of myelopathy. The primary care doc and oncology doc got a MRI of her cervical spine, which demonstrated this C5 lesion. They did not get it with contrast. We only have a without contrast, but clearly there's a lytic lesion seen at C5. You can see here in the MRI. It encompasses the entire vertebral body. There's mild cervical canal stenosis on the subsequent CT that we obtained. Looks like it is a lytic lesion causing a burst fracture here. There is some involvement in the posterior elements and the pedicles, but none in the lamina and or facet joints that we could see here. He has a SIN score of 14 for a mobile spine with pain, lytic lesion, some subluxation, greater than 50% vertebral body collapse, and I didn't give it full posterior lateral involvement given its facet and lamina uninvolvement. So either way, this is an unstable lesion needing some sort of surgical intervention in order to stabilize the spine.
So if we go back again, go back.
Oh, sorry.
So go back to the initial presentation films. So this patient has battled with breast disease for how long now?
About 3 years.
3 years. And how sure are we that this lesion is breast disease? Is there a thought about a biopsy, anything like that?
For breast cancer, it is, I think, one of the most common metastases to the spine. At least the bones of all the diseases. We could do a biopsy, but I think the approach for that biopsy would be just probably an anterior approach rather than a posterior, given the lack of involvement in the posterior elements.
So let me just ask our visiting professor, Dr. Amin, we're all, just like the previous infection case, kind of completely drilled into the thought that biopsy is the first step, and we should do a biopsy first for lesions to see what they are. This patient has a breast cancer history. The anterior cervical spine is a common site of manifestations of oncologic disease, yet a biopsy tract is not exactly easily to come by. There is an undeniable risk to esophagus and vessels. So what are your thoughts in terms of getting a biopsy to know what we're truly dealing with, to follow the dogma of biopsy first in a C-spine manifestation?
Yeah, I think I would lean towards not doing the biopsy in this type of scenario where, number one, you have a clear history of cancer, so very possible for it to metastasize. And then number two, as you said, pretty hard to get access here percutaneously. So yeah, if it had been thoracolumbar or somewhere posterior elements, sure, you can do that if to follow the textbook answers. But I think I probably would just go to upfront surgery here, which is, I assume that what you guys did.
I know sometimes in Tampa, we will typically get neuroaxis MRIs in order to see if there's another lesion. Let's say there's something in the L5 that they can easily biopsy to confirm, or even the brain, just to get kind of an overall prognostic factor as well.
This is where the CT helps us to find an opportunistic location, let's say a posterior lesion or a posterolateral lesion. This is where the CT helps us to find an opportunistic location. IR people, and I'm sometimes amazed how artistic they are in finding tracts for needles and getting tissues safely out, and at the other times a very obvious thing, they don't want to do it. It's always difficult. It's again a case of having really high quality direct communications with our colleagues who are on the same page and see the same things. Protocol-driven medicine is a big deal nowadays. How does this kind of a presentation fit into that? Is an algorithm in your institution to kind of just image these patients? I think Dr. Rao was talking about a neural axis MRI.
Yeah, same thing. We try to get, if a patient has known metastatic spinal disease, we try to get total spine imaging roughly every 3 to 4 months, and you'll be amazed with how much progression you're seeing, even though they're back on their systemic treatments. And this is largely in collaboration with our radiation oncology colleagues. So as you guys know, we're doing a lot of spine radiosurgery at UW. So you'll see a lesion maybe growing and these repeated scans that are asymptomatic. So we have that opportunity to ablate that lesion and then continue to follow the rest. So I would say even whether it's surgically treated or radiosurgery treated, we're probably seeing like roughly 30% of patients are developing another site, a tandem lesion down the road on these surveillance scans. So and that may be asymptomatic. So much easier to treat, and you have that time to decide on what's the right treatment if you're picking up something before they're developing symptoms.
Dr. Amin, in terms of longitudinal follow-up, it strikes me how a lot of patients with these more survivable diseases like breast disease, prostate cancer, colon cancer, are, quote, cured and then come back 5 years later with oncologic disease. Do we have anything better to offer in terms of long-term assessment of these patients, or is it just kind of like, I have new back pain, or here's a fracture?
Yeah, that's I think the $1 million question here is, can we sort of either predict who's going to develop a progression of disease down the road, or is there a better way of actively surveilling these patients despite expensive, timely MRIs of the body? So there's a few different people studying out there. One of the things we're investigating is following patients through just simple surveys through the Spine Healthy app that Dr. Hofster, my CM partner, has for endoscopic cases, but we're making a tumor module for that. So can we pick up on a change in their functional status before they actually become truly symptomatic? And then similarly, just tracking things like their gait, and are we having like a slow decline in their step counts before an impending event? So things like that we're working on, but still, I think this is the big quagmire where you'll have these patients who are cured, or they're on a really good new therapy, and then something will pop up down the road that makes it much tougher to deal with.
I'm going to harp on as a great point, and again, we, I think, still lack a tumor marker, something that we can try to, with less cost, invasiveness to our system, track on these patients. But clearly being aware, and I think educating our patients with these diseases, that the battle in the moment may be won for a couple of years, but down the line, being aware of symptoms, and whether it's simply subjective stuff without driving them nuts, or developing a tumor assay and immunologic test that just at least shows that a repeat follow-up would be necessary is very hopeful for the future. Here we are now. So we have something that doesn't look so hot, but fortunately for this patient, she came in before neurology developed, right?
Yeah, just had pain and some paresthesias, but no over motor weakness or
Now,
myelopathy.
Doctor, I mean, how do we assess the gravity of this? So Dr. Rao talked about the SIN score before, and Dr. Davis did that also. Is that something that is commonplace now at UW Medical Center?
Yeah. So basically, we teach our residents and fellows that to be including the SINs in their notes on their initial assessment for any ER patient that comes in, and it just makes it much easier to communicate with the attendings and the rest of the teams about giving them even just a simple score of, is it in the stable, mildly unstable, or highly unstable, just to get that rough idea, because a lot of times, as you guys know, these are complex patients, so we're trying to figure out you may not have a neurological deficit. For example, in this patient, there's not too much of a cord compression, so a lot of times this is the type of patient that may slip through the cracks in an oncology office, where they may not have much pain, may not have much deficit, but clearly when we all look at this, we know it's a fairly unstable fracture that's going to require stabilization.
So a couple of years ago, we had a really rude awakening, because we thought that the SIN score, which was developed by AO Spine North America and then had a global validation effort, and we have some of our colleagues actually on board. So welcome to Drs. Tariq Sohail and Sahil Majid. Great to have you on board. So we thought this is kind of it. Although there's some clear holes in this scoring system, there's nothing that identifies neurology outside of pain. There's no general wellness or protein count. Cachexia does not exist in here, which is like in the Karnofsky index, for instance, so important. So there's some holes in this, but we thought this is really good. And then we found that our oncologists have never heard of this even. Mm-hmm. And our radiologists, despite having a very integrated, all ex-UW, by the way, neuroradiology group with very sophisticated practitioners, had also not heard of this. So the language that we spoke or started to develop was not at all even recognized as a language by our quote team members. Was that just a local problem, or have you had that same observation?
Yeah, I think when I did my fellowship at Sloan Kettering, they have a very close-knit program that's collaborative. So every single radiology report will say, this is part of the SIN score, not accounting for pain, but everything else is in the SIN score. They'll put in their radiology reports with the epidural spinal cord compression. So that helps them just for research, because then every single patient you're already getting it tabulated, and then obviously to communicate amongst the oncologists, and that obviously increases the awareness amongst oncologists to look for this. So even if they may not be aware of the specific components, if they see in the radiology report, oh, highly unstable SIN score, consider a spine evaluation. So we're trying to do the same thing at UW, and with mixed results. So there are certain neuroradiologists who are incorporating it also, but sometimes on call you may have someone that's not familiar with it, and then same thing, you get this sort of vague description of the stability of the spine.
In Tampa, have you used the SIN score in the Department of Neurosurgery?
Yeah, we have our junior residents. Whenever an ER consult comes in, that's typically how they're seen. These patients usually present a lot of times with pain, and then they come in, we do their assessments, we see that they've had a history of cancer. So we'll get these lesions, we'll make sure that it's in the note right at the top, just so everyone's aware. But like you were saying, Dr. Chapman, a lot of times the oncology colleagues don't really understand, I guess, the SINs. It's really more of a stability marker rather than kind of an oncologic determination of saying how, obviously there's cancer there, so it's the disease has progressed, but it's more for really us to say, should we operate, should we not operate? So I can see how and why they kind of don't really care about it as much.
Having been involved in development of classifications over time and severity scales, one criticism I have on this in retrospect is the intermediate group is way too big. The point assignment in there allows for way too many things. Now, we realize we're not just in a binary world. There's many permutations of whatever we're seeing, but the middle ground here was invitingly overly large. Again, it did not help the cause to have it this big, I think.
Yeah, I think I agree with you. The discriminatory power of that middle group is the difficulty, because the patients who are in that low stability or low SIN score, it's going to be very obvious that they don't need some sort of intervention, and then the group in the highly unstable, it's very obvious they're going to be symptomatic from their fractures, and so where we need that help is that middle category, and that's the big issue, where a lot of patients get lumped in there, and there's a varied amounts of treatment algorithms at that point, because it's such a large group of heterogeneous patients.
All right, so you've shown what we've done already here, but
spoiled the surprise.
Yeah,
we ended up doing a C6 corpectomy. No immediate issues post-operatively, no dysphagia, she did get some relief in her neck pain and paresthesias. The pathology was consistent with the double positive breast carcinoma, like we kind of considered. And plan was for a subsequent radiation therapy for her.
Yeah, full disclosure, I may know this case.
Okay.
I think you guys may have sent for radiation with us, I think.
Possibly. She was doing well post-operatively, no issues. And then about a month and a half later, she developed kind of worsening pain in her neck when she was bending over, when she was moving around. And we ended up seeing her in clinic and getting a new CT scan of her. Fortunately, her motor strength and other neurologic exam was normal, consistent with her baseline, but she did unfortunately have some adjacent segment disease, some kyphosis at the C4 level. And we then subsequently took her back to surgery for a posterior instrumentation and deformity correction, seen here.
So going back to the decision of hardware, what in an anterior neck and an oncologic patient are some of the considerations in terms of biomaterials? I'm assuming you'll talk about carbon fiber implants later and stuff like that. Do we have anything that is less radiodense than this titanium implant here? What are some of the fine points in terms of how to reconstruct the C-spine in its anterior column complexities so it does not fall apart and allows for radio access?
Yeah, no, I think it looks like a great construct there initially, so I was surprised that it fell apart there. But I think the one thing that I often consider for the cervical spine is I try to avoid an anterior approach if I can. This one was obviously like a huge fracture, so it's just hard to avoid the anterior column support. But primarily the reason is that there's a high rate of esophageal perforations, and not just from the surgical approach, but the fact that these patients are going to need to get radiation right after, that surgery. So it's basically like a two-hit between the anterior approach surgery and then followed by radiation. So very high rate of esophageal perforation. And then obviously if you do it in reverse order, some patients may come in with neck radiation, and then it's always a much more difficult exposure and high risk also. So oftentimes I try my best to avoid going in from the front on these cervical cases and just try to do a long posterior construct. And then similarly, with one of the issues with the carbon fiber hardware out there right now is they don't, some of the companies out there don't have a cervical like lateral mass system yet. So they started with the traditional pedicle screws. So there's not much options there if you're trying to use the carbon fiber in the neck. And besides this type of, peak cage and whatnot. So so I think the principle for me is I try my best to avoid an anterior approach for a patient who's going to get radiation very soon because of the esophageal perf issue, not necessarily because of a hardware issue.
Have you noticed? So we rotate out one of the cancer centers down in Tampa for our oncology rotation, and they've started to do pre-surgery radiation, where they'll radiate and then a week later we'll take them to the OR. Mainly to get as much blood flow and free radicals in the tumor before rather than us going in and devascularizing everything. Do you think that'd be worth it for spine, given how rich the vascular territories are, or is that something that is still kind of surgery then radiation?
No, that's a great point. I haven't thought about that much in the spine, so I'm not sure how good if the literature is out there yet and defined. But I do know for that is an active topic for brain tumors right now, especially with like gamma knife or cyber knife, where a lot of times if you're taking out a metastasis, it's very hard for our radiation oncology colleagues to sort of plan the radiation afterwards. So now that you basically have this, it's just missing, and it's kind of hard to distinguish where the original planes were. So we're multiple centers, but us also, we're actively doing upfront stereotactic radiosurgery to the brain met, and then the next day taking it out. So to get that benefit and getting a better defined margin there. But yeah, in terms of before, after, how does that affect biologically? I think that's a great active part of research right now. So I'm not sure yet where that's going to go.
Okay, great, thank you.
How hard is it to go back in, and is there a timing issue, like the magic 3-week window between radiation or last dose and surgery? I've had to operate on many patients with radiation, and this is no fun.
Yeah, it's no fun. I know for cranial, it's like Dr. Amin was saying, it's usually like a couple days. They'll do it on a Monday. We'll take them Wednesday, just so it's still damaged tissue that we have to close. But so far, what I've seen when I was there, it hasn't been too drastic. Fortunately.
After seeing what you've seen here in this case, and if you go forward to that construct and hearing Dr. Amin's talk, would you change anything? What would you do differently in terms of the surgical care if you're a young attending now? She's young. Her bone quality was good. I was in the initial case. I don't think I would have changed anything. I think I would have continued with the corpectomy. I think if the bone quality was worse, then maybe we've done a 360 just to give her stability. But otherwise, I think getting the pathology was as important in this situation for her. I don't know. When I saw this case being discussed, this is one of those really controversial cases. I think the basic principles were very well followed. Rigid plate fixation with near bicortical screws, not violating the end plates if they're not oncologically diseased. I personally prefer allografts to these peak spacers, because the peak spacers are like the Great Wall in the Game of Thrones, reference for those who watch trash television like myself. But basically there's no healing around peak cages, at least in the traditional form. And titanium cages we don't want to use because of more radiation artifact. And they have to have a plate in front of them. Otherwise, talking about esophageal problems, I've had that in my UW days, where the esophagus would literally grow onto the cage and become a nightmare, and with significant adverse consequences for patients. So I struggled with when I saw this emerging. And again, obviously, we don't want to do a big, far more morbid procedure on the back, but she did actually well with that, right?
Right, she's doing well with that.
Yeah. But now from a radiation standpoint, this is a whole different challenge, right?
Yeah, I think a lot of times when you have this amount of hardware, it can make it difficult to visualize the spinal cord because there'll be a lot of artifacts, even if you're using like special MRI techniques to reduce the metal artifact. This is a patient that we typically would do a myelogram before radiation, but it sounds like she got the radiation right before that second stage, so hopefully she's fine with that.
Yeah, and I know in Tampa sometimes, this case is different because of her deformity, but let's say she just had, we would probably do a laminectomy there and then probably not put screws above and below just to give some extra room for the radiation to be able to penetrate, because that's really what is going to treat. It's not us. So,
Right. Well, thank you, Dr. Rao.
thank you.
Great job.
Thank you.
And we have one more case. Dr. Davis is so kind to put the percutaneous infection case together quickly, but in the interest of time, and our lecturer will probably not be able to do that. Sorry, but thanks for doing that. This is Neil Patel. He's here from Penn State, and it's been a blast to have him here, and he's going to be here for another half year.
Yeah, so I'm talking about a 71-year-old gentleman who had severe position-related pain. So when he stood up, he'd had significant low back pain and numbness in his groins, right greater than left. He had symptoms for about 6 months. Again, nighttime pain. When he got up, pain got to 8 to 10 out of 10. He had elevated PSA and had gotten a prostate biopsy and had kind of long history of urinary dysfunction. He couldn't stand up straight. He had to use a walker. Heel to toe kind of walking wasn't intact. Couldn't squat. Trendelenburg was positive bilaterally. Balance wasn't present. And his strength exam, again, hip flexors, knee flexors weak. A1C was normal, 5.6, albumin was 4.4, and BMI was reasonable. So this gentleman initially got just x-rays and could have kind of noticed some end plate deformity at L1. And then 1 month later, he was again kind of worked up by outside a hospital and got a CT scan that shows this L1 pathologic fracture, lytic lesions, no significant compression of the central canal. At this time, he doesn't have a primary oncologic diagnosis. So we pursued an MRI. Here's his MRI, T2s and T1 post-con, significant compression of the cord, involvement of pedicles bilaterally, involvement of the vertebral body more than 50%, starting to develop a kyphotic deformity, and no other lesions anywhere else. So CT chest, abdomen, pelvis was negative, MRI brain was negative. So this is his solitary kind of lesion.
And a very high grade, yeah, a very high grade lesion, and actually intolerable pain. He was basically in a recumbent position for the most time, and clearly in distress. But interestingly, not much in terms of objective neurology.
No.
It's just a slow growing process. And again, he'd been put on steroids, I think, pretty early on, oral steroids for the most part. But and urination, I think, was
A PSA, he had urinary dysfunction from before.
yeah.
Like
So
baseline.
that was not a reliable indicator. So thoughts on this? This is again becoming literally common daily things: breast cancer, prostate cancer patients, solitary lesion, SIN score. We talked about SIN score. Oh, good.
I got both. I got SINS and SITE.
Excellent.
So SIN score was 14. I put the numbers there, so how I got to it, and that clearly shows unstable and needs to be operated on. SITE score same. It's 8, so that's where we start thinking about operating. So I think this is clearly an operative lesion because, again, main things are junctional. It's at L1. He had some pain relief with recumbency and more pain with standing up. It's a lytic lesion. Involvement of pedicles is present. more than 50% vertebral body is involved, posterior elements are involved, and he's developing kyphosis. So all of those things kind of add up to a point where we should probably do something about him.
So do you agree with this assessment?
Yeah, I totally agree with this assessment. Great summary. High grade conus compression there. So even though he's asymptomatic right now, he's probably just on the edge of that cliff. Any more growth of that tumor, or if he stops his steroids, he could definitely develop some more bowel bladder issues.
So how would you approach this then?
Yeah, so I think the big question is, do you want to do a minimally invasive approach, or do you want to do something a little bit more bigger that's going to be more long-lasting and durable? So I think the consideration for the MIS approach is that you could probably get away with a very quick surgery, where if you were to just do percutaneous screws above and below, and then potentially a laminectomy, whether you do that through a traditional midline approach or tubular decompression, you'll probably get the job done. The cons for that, and what I would be considering for this patient for considering doing something bigger, is that if this is a solitary site of metastasis, newly diagnosed, presuming it's going to be, I assume, prostate given his age and whatnot, I think that his chance for survival and prognosis is probably much longer than your typical like full-blown metastatic patient, because this is his initial presentation. And so then you're going to have to start thinking about the longevity of this construct, and that's where I start. I think it's like an evolving space of, do you just go upfront bigger at this point, knowing that he's gonna have many years ahead of him.
Okay, Neil, take us forwards.
So given that he had some anterior area where there was compression from the lesion, we wanted to kind of address that as well. So we did 2 levels above, 2 levels below. Fusion with significant LAMI and decompression with resection of pedicles at L1 and posterior vertebral body as well, and cement augmentation of that region to give him some support.
And how do you do?
He did great. He left post-op day 1. His pathology came back, metastatic prostate cancer. He had no issues. His pain is resolved. He's able to stand up straight. Urinary dysfunction is still present, but otherwise doing really well. The symptoms that he presented with for pain, numbness are all better.
So again, this is something that is definitely debatable. I mean, we decided to do a open procedure. One of my great mentors is an Italian gentleman named Stefano Boriani, who told me that the main disease in these metastatic spine patients is below the PLL. So I resect the PLL above and below to get disease clarity in terms of the epidural progression. And here we did not do a full corpectomy. We did a more or less curettage of the lesion. We patted in the cement. We're a little bit shocked to see that the cement was a little bit more posterior than what I thought, but you were there for that. We thought we had a very nice clearance, and then post-operatively, the cement looked more proud than what I thought, but he had no neurology from it. And this allows our radiation colleagues to have wide access, so there's not a titanium cage in there that's deflecting the beams. And so this is what I learned from Dr. Bilski, that cement is actually a very good biomaterial. So what are your thoughts in terms of an elderly patient doing kind of a damage control surgery like this, where we combine an open, clear separation surgery with a reasonable mechanical fixation? I think we did a 4-rod construct also.
4-rod construct, yeah.
So there's a 4-rod construct. There are no transverse connectors over the main lesion site. Maybe one. Maybe we put one over there. Darn. But the main vertebral body is accessible. Do we have to do a full corpectomy? Is this a reasonable construct?
Yeah, I think this is a very reasonable construct. This is exactly what we would have done in fellowship with Dr. Bilski also, where basically truly just doing a dorsolateral decompression, going down the pedicles like you guys did, and same thing, defining the PLL, cutting the PLL, and then removing all the epidural tumor that's deep to the point where you get reconstitution of the thecal sac. So I'm not sure if you guys do this also, but I use the intraoperative ultrasound all the time for all these type of cases, and I keep resecting epidural tumor until I can see like a nice cut of the axial cord.
We have a fan of intraoperative ultrasound right there. You made Dr. Patel very happy. What are you going to do, Dr. Patel, in your practice?
I agree with this. I would have done the same. Decompression. We used a Woodson to make sure that our cement was further away from the cord. But again, as you mentioned, it'd be nice to have, again, look at it again. But post-operative, we had no symptoms. So I think this is what I would do.
Great. Thank you, Neil. Thank you to our fellows. All right.
Yeah.
So I hope all of you who've joined us this morning found the case discussions meritorious. And again, they show ongoing problems with infection management. The stepchild of spine surgery needs a home. And common diseases in the oncologic arena are, again, breast, prostate, lung cancer could add to that, rectal, colon cancer, very common problems. It's great to have Dr. Anubhav Amin here, assistant professor in the Department of Neurological Surgery at the University of Washington, mainly based at UWMC. And he is, again, a spinal oncologist who came with an interesting background from Johns Hopkins, where he did medical school. And he did a research fellowship, which is really near and dear to my heart, on molecular mechanisms of recovery in chronic spinal cord injury and functional electrical stimulation therapy. He did that at the Kennedy Krieger Institute, so this was really very near and dear to my heart again. He did his residency at New York Medical College at Westchester, and he did his fellowship, as you already heard, at the Memorial Sloan Kettering Cancer Center doing spinal oncology. And being a younger surgeon, he is going to show us how to use less invasive strategies to have better outcomes for oncologic patients. Thanks for coming over.
Okay. Good morning, everyone. Thank you for having me over. So today we'll be talking about minimally invasive treatment options for metastatic spine disease. Here are my disclosures. We will be talking about some Globus implants and retractors today. So again, the objectives today is just to describe first the advantages to using minimally invasive approaches specifically for spinal oncology. I'll discuss a little bit about my workflow discussion and then one or two cases here, and then specifically talk about enabling technologies such as navigation, robotics, possibly entering and trying to incorporate endoscopy into the oncology workflow. So I think the first thing to discuss here is, we are seeing a lot more patients presenting with metastatic spine tumors. More than 20% of patients with cancers will eventually develop a spine metastasis. This is increasing in prevalence for a couple of reasons. Number one, we're just having better detection methods with more frequent MRI, surveillance scans, PET imaging, and then a lot of these patients are surviving much, much longer as we're moving the needle, advancing the medicine and their prognosis via various systemic treatment options, biologics, checkpoint inhibitors, targetable agents. And there is some thought that perhaps some of these newer agents that are very target specific, they may have good penetration through visceral organs in the bloodstream, but they may have limited response going through the bone as well as the brain, the blood-brain barrier. So we're seeing a lot more cerebral mets as well as spine mets. And then furthermore, we're having much better local tumor control with stereotactic radiosurgery. So again, these patients are surviving longer and they may develop subsequent lesions down the road. And I think one of the important things to distinguish today's topic from other recent topics that I've seen at STED is I'm specifically talking about metastatic spine tumors on patients who may have a full-blown disease and a limited survival, and trying to balance the perfect surgery in terms of picture perfect versus what they actually need. Whereas in other scenarios where you're dealing with primary bone tumors or sarcomas or someone with an oligometastatic disease where they only have one site, that type of patient, they may have many years to live in terms of their prognosis. prognosis. So you may want to choose a bigger operation, something that's more durable, where this is a totally different clinical scenario. So in this type of scenario that I'm talking about, we're really talking about palliative pain control, palliative goals here. The ultimate plan here, the ultimate goal is improving the patient's quality of life. So that's going to be obtaining pain control, stabilizing the spine if there's a fracture, protecting their neurological status, and then just local tumor control. We're not going for, necessarily a grand slam here of, there's no illusions of achieving oncological cure in this type of scenario. So knowing that our surgeries are more palliative, how can we minimize the damage that we're causing through the surgery so that these patients can get back to what they need to get back to, which is their systemic treatments. So as you know, with these metastatic patients, we're going to have a multidisciplinary treatment approach, relying heavily on our oncology colleagues as well as our radiation oncology colleagues. And so oftentimes we're not making these surgical decisions in a silo, and we're often involving them and asking our colleagues of, okay, what's the next line of treatment now that they've progressed? What does that mean in terms of the prognosis? And of course, it's going to be an individualized plan for each patient, depending on where they are in their stage of their disease. So from our standpoint with the surgeries, there's various options we may have for in terms of invasiveness. Oftentimes we may get away with just some percutaneous procedures like a kyphoplasty or vertebroplasty versus, as we just presented in the last case, a smaller resection such as the traditional separation surgery versus something much bigger if you're dealing with something that's either like a sarcoma or an oligometastatic site where you may want to do an en-bloc surgery. So we'll briefly go quickly into the NOMS criteria, which was developed at Sloan Kettering by my fellowship mentors. But basically, when we're working up these patients, we're looking at these four categories of the neurological status, the oncologic status, their mechanical stability, and then just what's going on systemically in terms of their prognosis. So of course, with neurologically, we're looking at symptoms-wise, do they have myelopathy? Are they at risk of developing myelopathy or radiculopathy? And then with MRIs, we're also categorizing their degree of epidural spinal cord compression based off of a T2 axial scan. And then oncologically, what is the pathology if it's known, and how sensitive is that histology to radiation? And then, of course, we just talked about the SINs, and I think this is where we need to kind of push this forward, the SIN score. And as you said, that many radiologists, many oncologists may not be aware of this category of, considering the spine instability score. And that's where we get involved with that, and just really trying to understand how does that pathologic fracture, does that tumor affect their ability to withstand physiologic loads? And then finally, systemic, talking to the oncologist about what's the extent of their tumor burden, what's their prognosis, what other comorbidities do they have, and how is that going to play into the picture of their surgical framework. So again, just going into in-depth for each of these, we have the N for neurologic, and primarily we're looking at what is the degree of cord compression on a MRI T2. So I basically just break it down to grade 0 and grade 1 as being low-grade cord compression, where you either have disease that's within the bone or just entering the epidural space but not causing cord compression. And then the high grades would be grade 2 and grade 3, where at grade 2 you're getting cord deformation, but you still have some preservation of CSF space, versus 3, where you're having a high-grade cord compression with no CSF available seen on the imaging. And these other two may become much more surgical. And then we're pairing that with the oncology portion of like, what is the histology? There's certain blood-based cancers like lymphoma, myeloma that are very radiosensitive, and we're talking about sensitivity to conventional radiation versus a lot of the solid organs like renal cell, non-small cell lung cancer may be very radio resistant here. And this is going to come into play of how much of a decompression do you need to do. And basically, in terms of conventional radiation, if you have one of these radiosensitive diseases, you can get a median duration of response of tumor control of about 11 months, 2-year local control in 86%. But if you are providing conventional radiation to one of the solid organs, your median duration is going to be less than 3 months, and local control at 2 years is less than 30%. So a huge difference depending on the oncology, the histology. Then, of course, we just talked about the SINs. So the categories we're looking at is, well, where is the location of the tumor? Is it at a junctional level? Does the patient have pain? Is it mechanical? Is the tumor causing a lytic lesion or a blastic lesion? And then is there any misalignment with subluxation or kyphotic deformity? And then finally, is there a vertebral body collapse or fracture? And are the posterior elements involved? And as we discussed before, this will break down into 3 categories of stable, indeterminate versus unstable. And as we know in the real world, many patients will kind of fall into this middle category, which makes it a little bit difficult in trying to distinguish what to do with these patients. But from what we're trying to do at our cancer center is that basically anyone that falls into like a SINS of greater than 7 should at least just get a spine evaluation. And I think that's a little bit easier to kind of develop a program with our oncology colleagues with that. And then I think the biggest thing about these metastatic patients in terms of this minimally invasive approach is the evolution of an integration of stereotactic radiosurgery or SBRT, stereotactic body radiotherapy. So you may have had 10, 15, 20 years ago, a patient with a solitary renal met where we're trying to do en bloc resection or to get with either curative intent or trying to get really good local control. And this would have been a very long resection. In this case report, we're talking about 15 hours, significant blood loss, beautiful scan. But nowadays, with the modern integration of SRS, this patient may have actually just skipped surgery completely since there was not high-grade thecal sac compression. And this would have been a 20, 30-minute outpatient procedure with no blood loss and having comparable control rates. And so I think the big question is, how do we, now that we know that we have great radiosurgery technology and we're dealing with a medically frail, sick patient population, how do we incorporate smaller surgeries so we can get them back onto their medications or radiation? So I think the adoption of minimally invasive techniques for spinal oncology is really a bleeding edge right now. As you all know, we've been using MIS extensively for other pathologies such as degenerative spine, trauma, deformity. And through that literature, we do know that MIS techniques lead to less tissue disruption, smaller incisions, potentially less operating time, certainly shorter hospital length of stay and less narcotic usage. So this all applies for the spinal oncology population where, we're dealing with patients who are very medically frail. They have poor wound healing because of the certain medications they're taking for systemic disease. They may be taking significant opioids even before their spine metastasis because they have intractable cancer pain. And then anytime we do an intervention or surgery, we're going to be requesting a pause in their systemic treatments. And so anytime, if you're going to do a much, much bigger surgery that may put the patient at risk of a morbidity or complication, you're just going to have a longer delay and getting the patient back to their systemic treatment. So really the benefit of adopting these MIS techniques is that we can achieve the same surgical goal while minimizing disruptions to their systemic treatments or their radiation treatments. We just discussed in our last case presentation separation surgery. So again, the technique is stabilizing the spine, usually 1 to 2 levels above and below the tumor level, doing a posterior lateral decompression, typically involving a wide laminectomy, either unipedicular or bipedicular resection, and then finding that PLL that's ventral to the spinal cord, and then getting the epidural tumor resected circumferentially. And the ultimate goal here is just to provide a good target for our radiation oncology colleagues. So now I think the big question is, we know that separation surgery is a very viable option and it's becoming much more popular, but can we continue to advance that, making it smaller and smaller surgeries? So I think this is where enabling technology has a big role of letting us get to an even smaller surgery. So I think the big things that I look for my cases is basically I always come out with the framework of, can I achieve that goal with the smallest type of surgery? So in terms of open fusions, if we're having a patient that may have a short survival, predicted prognosis, then we're sort of converting to, can we do a percutaneous fixation instead. Oftentimes I'll go to a shorter construct now that we have cement augmented screws that are FDA approved. These fenestrated screws have made a big change in my my workflow. And then finally, just vertebral augmentation. And then obviously in terms of the decompressions, as we just described before, the traditional separation surgery, we're also trying to limit that as well with either tubular retractors, expandable retractors, and now we're venturing into endoscopy and robotics. So again, I often use Globus for my cases here because they have a lot of different options in terms of for these oncology patients. So in terms of vertebral augmentation, we just talked about doing kyphoplasty, vertebroplasty, especially if you're having a pathological fracture where it's not involving the posterior elements and you're just trying to get some anterior column support. Again, I try my best to do as much percutaneous fixation as possible. And then with the Creo system, they also have fenestrated screws. So for me, my workflow is I try to use enabling technology such as navigation for almost every single case if it's available. So as you know, with cancer patients, they're going to have poor bone quality. So you may either get suboptimal imaging on fluoroscopy, especially if you're doing percutaneous, where you're going to be depending on that fluoro a lot. And then you don't have the same tactility feel because they may have a very softened bone, brittle bone. And so you're not going to necessarily feel that cortex as well with your Jamshidi needles. So I try my best to use navigation for every elective spine case we get. And the idea is that we're just going to have improved visualization with the 3D reconstructions, increased pedicle screw placement. And then this also allows me to go with a smaller construct because I can go with a much longer screw that's optimized for that tract. I can go for the biggest diameter that can fit through that pedicle by using the navigation to help plan that. And then similarly, I often cement my screws since these patients have poor bone quality and I want better purchase. So if we're having better screw placement accuracy, I'm going to have less revisions, less breaches, and that lowers that risk of cement extravasation. So my typical workflow is that we'll do a 3D spin with whatever fluoro-based or 3D-based imaging software, intraoperative imaging we have. And then I'm planning every single perc screw from the skin incision using the navigation to get the idealized trajectories so I can get the longest screw with the largest diameter. And so oftentimes, we're integrating that in from the very beginning, planning our incisions, seeing do those incisions make sense with how the rod is going to align. And then similarly, we're just checking with the navigation system once we get docked down, and then also planning the screw size and diameter with the navigation systems. And again, with the Creo fenestrated system, I've been able to get a smaller construct because now we can cement augment the screws. So very often, if it's not a super highly unstable lesion at the junction, I may just do one level of fixation above and below and augment the screws instead. I do prefer their system that uses a plunger, so I can have really good control of the cement under live fluoro. So again, what may have been like a mid-thoracic lesion on a patient with poor survival that you think is not going to fuse, we may have done 2 to 3 levels above and below in the past, but nowadays I've really converted to doing just one above, one below fixation with cement augmentation of those pedicle screws. And then instead of putting in a fairly expensive titanium cage, which makes it difficult for radiation planning and for surveillance, just augmenting the pathological level with a vertebroplasty or kyphoplasty. And this totally reduces the blood loss, the morbidity. And so again, here just showing some live fluoro, intraoperative fluoro with after placement of the screws and the Jamshidi needle at the tumor level, just get really good control with the cement injection. And then in addition to stabilization, I think the next big step for us is, can we get away with a smaller decompression and just relying on the postoperative radiosurgery afterwards. So we've been moving to using more of the expandable retractors. So very similar to just adapting whatever we know from our degenerative or trauma cases. So similarly, we become very familiar with doing XLIF lateral approaches. So using those similar type of retractors, and now instead of using it in a lateral approach, but putting it in a posterior approach, getting some dilation of the muscles there off of a paramedian incision approach, and trying to decompress via these smaller incisions and smaller tissue disruption. And then also we have custom ports to help with decompression as well. So this has been great for if you're having like a unilateral disease, perhaps just down one pedicle. So we can just dock and down one side, and then bring in the microscope and just debulk that tumor until you can get the fecal sac nicely decompressed. So one of the things that I use regularly for my patients is this minimally invasive algorithm that was developed by my fellowship mentors at Sloan Kettering, where basically if a patient comes in with a pathological fracture, the big first question is a decompression needed? If so, then the MIS option would be percutaneous screws and then a mini open decompression, whether that's a tubular port or an expandable retractor, up to you. If a decompression is not needed, but the patient does have mechanical radiculopathy, this is oftentimes what we'll see in the lumbar spine. Then again, that's where I would use percutaneous screws and then a unilateral decompression through a tubular retractor, such as like a pedicle resection or unilateral facetectomy. Finally, if you do have some core compression, but it's a radiosensitive tumor like myeloma or whatnot, then I would just do percutaneous screws and without a kyphoplasty, because you're worried about cement augmenting a tumor level that has significant core compression, and then I would depend on the radiosurgery to deal with the tumor level. And then if the posterior elements are involved, then I know that a kyphoplasty would not be enough, and that's where you would do a perc screws plus kypho. But if you're having no cord compression and no posterior elements involved, that's the patients that would benefit the most from cement augmentation. So just a quick case example here. Here is a 61-year-old male, non-small cell lung cancer, presenting with back pain, as well as L3 radiculopathy from a L3 vertebral body met. So what you can see here is that this patient has somewhat just unilateral disease down the left pedicle and going into the lateral recess. So this would be a case that you don't need to do a traditional decompression here. It's all unilateral, but they do have significant mechanical radiculopathy. And so this would be, for me, a perfect case for doing percutaneous screws and then just a tubular decompression, drilling some of that pedicle and drilling out the facet to free up the L3 nerve root. So you can see here how small and how minimal you can get at this point now. So we did an L2 to 4 percutaneous screws with cement augmentation, and then basically just a hemilaminotomy and a facetectomy here. Patient was discharged on post-op day 2. And then the other benefit of these small incisions is that I feel much more comfortable with the patient resuming their systemic treatments and going to radiosurgery as soon as possible. So in this scenario, the patient received it at post-op day 14, but we've done it even earlier, up to day just 1 week after surgery. And this is more of an issue of not necessarily me waiting for the radiation, to let the wounds heal, but rather that sometimes it just takes longer to plan the radiation and get the necessary imaging. But you can see this patient here, just a very, very small decompression, getting that epidural tumor out. And then on this post-op myelogram, you can see that that nerve root was free, but all that disease was still there. But you can see because the facet was resected, that nerve root is going to be nice and free. And so this patient had great relief of the radiculopathy, and then they proceeded to radiosurgery 2 weeks later to get a local tumor control. So this minimally invasive approach has been validated in the literature by mentors at Sloan. So, they had a prospectively collected PRO data for MIS and specifically for spinal oncology, and that's been shown to decrease their patients' pain severity as well as their symptom interference with their daily activities, and just statistically significant throughout. So you're really able to achieve the goals of the surgery through an MIS approach. So I would say for MIS approaches for spinal metastatic disease, in my experience, these techniques do allow me to safely and effectively decompress and stabilize these fractures in patients with spine mets. And then these patients that have mechanical instability, they may benefit from these percutaneous stabilizations using these fenestrated screws to allow for cement. And then patients with spinal cord compression benefit from a minimally invasive or minimal access approach, whether it's using a mini open, a tubular, or even thoracoscopy, or now we're entering into endoscopy. And then finally, these patients who do undergo minimally invasive approaches, whether it's with the percutaneous screws and whatnot, we believe that's decreasing the risk of postoperative wound complications as compared to an open approach. And then just a quick detour into the next bleeding edge, which I think is going to be endoscopic separation surgery. So we've done a handful of cases. This is still pretty new, and we're trying to figure out the best case scenario. So this was a patient, 32-year-old with thymoma. With I would consider relatively low-grade cord compression. So this was epidural Bilski score of 1C, where the tumor was just abutting the spinal cord, but you can still see like the cord is not significantly deformed, and it's not. You can still see the CSF presence. Now, what was interesting about this case was that the patient was planning on getting proton therapy by the radiation oncologist, given the histology. And so with the proton therapy, they have told us that they cannot get a contoured as nicely as with stereotactic radiosurgery. So they still wanted a separation type of surgery here in this scenario. And then similarly, the downsides of proton therapy is that they have a huge difficulty with planning radiation through titanium because of the protons particles are going to have some mass to it, and it's going to deflect off of the titanium. So basically they asked us, is there a minimally invasive option for separation surgery without using hardware? And so this was our first case example of attempting an endoscopic separation surgery. So I performed this with my mentor, my colleague, Dr. Hofstetter, who, as you guys know, is an expert with endoscopy. So basically, this was at T3, T4. We did a transforaminal approach here, so you can see us bringing in the initial needles and dilators at that area, and then reaming the transforaminal route corridor. Here you can see us getting the cautery device and using that to confirm that we've reached beyond the pedicle. And then again, very, very small opening here, but you can see that there's some bone just dorsal to us, and then you can see that we were seeing spinal cord, and there was an epidural disease here adjacent to one of the nerve roots at T3 nerve root. So we were able to just in a piecemeal fashion resect this, and we lysed that exiting nerve root. Very small approach here. Again, here's a pre-op versus post-op. Again, we just went for this epidural disease that was sneaking in through the foramen there. This is the post-op MRI that our radiation oncology colleagues used for their radiation planning. So you can see that we resected that part that they were worried about for the radiation plans. And so that patient, this was outpatient surgery, left the same day, and he went to radiation the next week. And then we're also venturing into robotics. Again, this is not necessarily the traditional spine robotics where we're talking about for pedicle screws, but using the devices that our colleagues in general surgery and OB-GYN use, such as like the Da Vinci robots. And so these multi-arm robotics, they take advantage of operating through a large cavity. So we've started to partner with our colleagues and who have much more experience with the Da Vinci robot, specifically when we're having a lesion that extends into multi-compartments. I think this requires a very steep learning curve, as most spine surgeons are not trained under this during their traditional residency or fellowship. And so that's where we lean heavily on working with our colleagues who have a lot more experience with this. And then also, in addition to the steep learning curve, there is limited tool set specifically for bony work that we're used to using. So this is great for soft tissue tumors that are in the specific cavity, and this can allow you to minimize how much spine surgery you need to do. So for this large thoracic tumor, we actually did not even need to do a spine fusion because we went in through a traditional thoracic approach with our thoracic colleagues using the robotics. And going in through that, using the Da Vinci, we were able to really find that exiting nerve root where this tumor was coming off of. We could even put in a neurostimulator using just the ones that we would use for like a lateral lumbar interbody fusion, a long probe, stimulate, make sure there's nothing too significant with the stimulation, sacrifice that nerve root, and then our thoracic colleagues were able to debulk this entire tumor out through small ports through their Da Vinci robot. So in conclusion, I think the role for surgery in these patients with metastatic disease with limited prognosis is going to be just doing a separation surgery to create a safe radiation target with ultimate goal of just preserving neurologic function and then stabilizing these pathologic fractures where we think we have a high SINS score. And then minimally invasive techniques aided with enabling technology can be adopted to achieve surgical goals while minimizing disruptions to systemic therapies. Okay, thank you guys so much.
Really nice overview. So we had a couple of questions in the chat room. So thanks for coming over. Sorry about your injury, but you'll in best hands with your future care. So the chat room questions were, for instance, in terms of radiation dosage, can you put more radiation dose into a patient by doing separation surgery? Is the quantifiable leap worth the effort?
Yeah, so basically what our radiation oncology colleagues have told us is that they need somewhere around 2 to 3 millimeters of separation between the epidural tumor and then the spinal cord. And then that gives them that opportunity to give a super high dose of radiation to achieve durable tumor control at that local site. So we do know that there are studies out there where people have looked at what the Bilski score is after surgery. So if you went from a Bilski 3 to just a Bilski 2 versus a Bilski 1C, and so the more separation you get, the better resection you get, then the better tumor control you're going to have after radiation.
And do less invasive surgeries actually shorten the interval until you can radiate a patient? Like we classically tell patients in a conventional surgical approach that they have to wait for 3 weeks until they can start chemotherapy or get radiation. We close the wounds in like 4 or 5 layers. We have nylon in there, no staples. Nylon sutures stay in for like 3 months plus. But can you actually shorten the interval? Can they have radiation like a week after your surgery?
Yeah, so that's what we're trying to move for. So at this point, the delay or the interval between surgery date and radiation date for me is not necessarily us holding them back. It's just the logistics of getting radiation planned. So oftentimes what we're doing is we'll do a surgery and we try our best to get an inpatient hospital myelogram so that the radiation colleagues can start planning that radiation right while the patient's still recovering. We typically see our patients 1 week after, and if the wound's looking good, then we can proceed to radiation. So we're trying to cut down that interval to about a week or so. I would say realistically, just because of logistics, we're probably on average hitting around 10 to 14 days after surgery. Another interesting thing that we do is that when the patient does get the inpatient myelogram, we often close the skin with staples. So we tell our radiation oncology colleagues to avoid the staple line when they're planning their radiation beams. And this also allows us to feel more comfortable with delivering radiation early because we know they're going to be doing their best to avoid blasting through the incision site.
And then the other question was very pertinent to the cemented screws that you were a strong advocate for. Dr. Isam Mardini, I want to thank you for that. How hard is it to take those screws out when you have to revise those for some reason?
Yeah, so when you inject that cement, those screws are going to have really good pull-out strength. So that's the idea of why we're using them. But in terms of screw revisions, if you start to just twist them, you're going to crack through the cement, and then you can take them out. So I was worried about that initially for these revision cases, but actually, as soon as you start turning the screws to loosen them out, they will crack out of the cement, and then it's not too much harder.
Great. Rod, any comments?
No, I mean, I think this was an excellent talk. I think oncology, there's no question, with all the technology that's come out, I think wound healing is a huge problem. So I agree with your approach, and that I think, minimally invasive surgery for those patients, I think, is a game changer. So great talk.
Thank you guys for having me over.
Yeah.
Thank you. Thanks for coming over. So Richard gives us approval.
Yeah, thanks for coming over.